I'm Dr. Jay Anders, and this is Tell Me Where It Hurts, where we discuss some of the big challenges in health IT and how we can solve them so clinicians can do what they do best, care for patients. I'd like to welcome everyone to another episode of Tell Me Where It Hurts. Today's guest has been in this industry for a very long time. And through iterations of products that I've been both competing against as well as a part of developing. So it's kind of an interesting path this particular guest has done. There's big news today. I will announce we have a new HHS secretary as of the date of the recording of this podcast, and we'll be seeing what kind of issues we can talk about during our discussion today regarding some possible policy issues and things like that. Should be a really great conversation. Today's guest is Leigh Burchell, who is Vice President of Policy and Government Affairs at Altera Health, who is a Medicom partner. She's also the previous winner of the HIMSS Most Influential Women in Healthcare Award. She supports Altera team members in complying with the many rules, and there are a lot of those, now affecting the company and its clients. She also works to ensure policymakers and are aware of implications of potential and current laws and regulations. And we'll talk a little bit more about that later as well. And maximizing the long-term relationships with those both government and other stakeholders across the industry. I'd like to introduce Leigh Burchell. Welcome, Leigh, to the podcast.
Thanks so much. Happy to be here.
Well, let's first start with you. And how you got to where you are today. Like I mentioned before, you've been in a lot of companies, all of which have now been rolled up into Altera over the time period. We've had a lot of interactions with folks in that path. I have personally. So it's been a real interesting road. Tell me how you got started down that road and how'd you get interested in healthcare policy?
Yeah, I mean, it's a funny question because honestly, it goes back to my childhood. Career path was not necessarily a direct line here. I started having graduated with a constitutional history major. I went to Wesleyan University in Connecticut, and you can form your own major. And so under the American Studies umbrella, I was really interested in the Constitution in the US, the policy world and politics and all of that. And so I worked with a professor to come up with a constitutional history major, and then promptly took that and started working in public relations and marketing. So not a straight path, but back in high school, I was kind of a nerdy, studious girl. And I was on what was called the U.S. Constitution team. It was a competition. And I just loved it. I loved everything about DC and how laws are made and regulations and all of that kind of stuff. And so even though I started in marketing, I think, I always was aiming for this. I thought I might go to law school. I ultimately decided not to, but, found a way through some mentorship and opportunities. And I would say happy coincidences in government, President Obama running and starting to talk a lot about health IT. And so it opened a door for us to establish a government affairs function at the company. It was necessary, right? The industry was shifting a whole lot. And, someone came to me and said, hey, we know you have this interest in this background, and we want you to build a government affairs function for the company. And that was back in 2008. We saw kind of the writing on the wall that health IT was going to be regulated and all of that. And, the rest is history.
Back in the old days of CCHIT and meaningful use.
Exactly.
All of that
pre-meaningful use, right? Yeah.
Yeah. All that heartburn that caused all of us who were actually developing systems back then. But it's actually gotten better, I think, over the time. And I think the regulations actually were very needed at that point in time.
Yeah, I would agree.
You are also chair of the EHRA.
I am.
Which is a very prestigious position. tell us a little bit. I'm going to change some order here. Tell us a little bit about the EHRA and their role and your role in that organization.
Yeah, sure. So EHRA is the trade association for EHR software developers. So, the vast majority of us now do more than EHRs. We really are a health IT trade association. It's the association has been around for 20 years. Last year was our 20th anniversary. And, it was initially established as being really a place for vendors to come together and collaborate on things that we were all concerned about, right? We all still compete. We're all still off, running our businesses and doing all of that. But we found that there was just more and more that was happening in the industry that, we wanted a place to come together and to share ideas. And so, that was back in 2004. It has grown extensively. So at this point, we have just under 30 member companies. Definitely the vast majority of EHRs that are in use in this country by healthcare providers are supported and developed by members of the association. But the place you can really see that we've grown is we have 12 different work groups and task forces now. And so the way that we work is we identify hot topics, areas that people, are losing sleep or doing a lot of work or, that type of thing. And when it's kind of a collective mass of people really thinking about something, we form a work group or a task force. And so we have task forces and work groups on everything from AI, public policy generally, standards and interoperability, patient safety, delivery system reform and quality measurement. So kind of the value-based care concept. Really anything you can think of that's a hot topic in health policy, we have a group on, and it's all volunteer. We do have support from HIMSS in terms of professional staff, but everyone who's in those work groups and task forces, we're taking time to come together and share ideas and brainstorm and try to address some of the things that are, causing us all some heartburn, or where we see opportunities, of course, as well. So it's a great group. I get a tremendous amount out of it. This is actually my second opportunity to be chair, which I'm really appreciative of. But it's a fantastic group, such smart people coming around the table and working together, and so collaboratively. It's really a really fulfilling opportunity for me.
Let's talk a little bit about the heartburn.
Yeah.
So what are the, there seems to be, we'll get into that a little bit later too. There seems to be a lot of changes going on right now. So what are the couple of top 2-3 items that concern the group of vendors that are creating these systems, as well as their interaction with the government and how that's going to go forward?
Sure. I think at the highest level, I would say we are a very highly regulated industry now, right? So when you look back to when I first started building that government affairs function for Altera, which at the time was under Allscripts, we were regulated, but not highly. And it was really the days of meaningful use. It was the days of, people starting to pay more attention to health IT companies. Now we are highly regulated. The majority of software developers do offer certified products, and the certification program, of course, is highly prescriptive, and so it tells us a lot of what we need to be doing in our products. So there's that part, but there's also a whole bunch of other agencies, both federal and state, that have discovered, how much health data is out there and how much opportunity there is from that data, but also kind of wanting to tell us what we should do in our software to expand access to that data. And so one of the things that we struggle with certainly is just the sheer volume of things that we're told we need to do, either directly ourselves or maybe our clients are told via a new law or regulation or something. You need to report X, or you need to send this information over here, this clinical data, maybe to an immunization registry, right? Or electronic case reporting to the CDC. So an edict will come out, and we then have to, get that done. The timelines are very frequently not realistic. So that's a big headline for us, is that, a colleague of mine at Epic uses this great analogy. you have a balloon, and if you squeeze the size and you're saying, here's all this work, you need the timing to be a little bit bigger, right? Or if your timing is compressed, you need to shrink the scope. And so you can't be squeezing both ends because it's going to pop. And so, I like that analogy, because we need recognition and pragmatism from the policymakers to reflect that, or else we end up with this, running on a treadmill as fast as we can to get stuff done, really in pretty unreasonable timeframes.
Well, I've had several conversations with the outgoing ONC, Mickey Tripathi, about a lot of the initiatives that have been going on the last several years. Their focus has been probably, for the most part, on interoperability and information exchange and how that's going to work, and how it's not going to work. So in light of that, where do you think we are with those types of regulations and information blocking? We've now on the second iteration of those and trying to get those implemented. So where do you think we are now? Because I think personally, I'm in healthcare IT now, but I practiced for 20 years. And one of the things that really was one of my soapboxes is I need the medical records from everybody. If I'm going to see you as a patient, I want to know everything there is to know about you without having to ask you, because that in itself has issues. So what do you think we are with some of those interoperability standards and information blocking? And how do you feel how we're going to be going forward with that?
Sure. I think that you're asking two questions kind of in the same question, right? So from an information blocking perspective, I think that law passed, 21st Century Cures passed at the end of 2016, so a long time ago, definitely had an impact on the industry, certainly on software developers. So we have an information blocking compliance task force among the many groups that I was talking about, something we collectively take really seriously. And I know within our company, we put in all kinds of processes and policies and internal reporting structures and things like that, because it's a really serious issue. And we're really committed to making sure that information is flowing everywhere that it can be flowing. I think there is a weakness as it sits right now within maybe the law, the statute itself, the regulatory construct, where the disincentives for provider organizations are pretty weak and not necessarily motivating the change that I think policymakers wanted. That certainly is true when you look at the fact that they've really only provided disincentives to people who are using certified health IT for the most part. And so you're not seeing the disincentives applied to other stakeholders like labs or pharmacies or providers who aren't using certified health IT, right? Generally, whether they're a physician practice or a long-term care organization or that type of thing. So there are definitely some gaps there. So information blocking, I think, still needs some progress and some iteration. As far as the general state of interoperability, millions and millions and millions of records are exchanged every day. So the progress there is astonishing and deserves applause. And I think a lot of times, we see good things and we go, okay, fine, but right. And I want to recognize how much progress there has been. That has been because of standards development. More and more use cases for exchange have been addressed through standards development organizations like HL7. And so we have more consistent ways that Altera can work with, Athena can work with Epic and exchange information easily for our clients, right? So I think that is a real positive. TEFCA is certainly another force for exchange. TEFCA is an interesting one because there's no mandate. Mickey, as you know, spoke many different times about how they didn't believe they could put a mandate out. They didn't believe that Cures gave them that authority. And so it'll be really interesting, in my opinion, to see some providers are really interested and hopped on board the second they could. And, we're eager to do that. But there are definitely others who feel like they have a lot of other things to worry about and they have limited resources and they aren't 100% sure. They feel like maybe in their local HIE, they can get the exchange that matters to them 97% of the time. And so that's maybe good enough for them. And so, I think it'll be interesting to see more and more vendors rolling out TEFCA connectivity, making it available to their clients. Do we see more and more uptake, or do some clients just say, I don't really care about that right now, I'm going to push that down the road? And I think that remains to be seen. That's going to be an interesting thing to watch.
Looking at the provider side of that, you mentioned the fact that this could be good enough. This part of it is good enough. Interestingly, that the state of interoperability right now, the things that are being transmitted may or may not be useful at the point of care for a provider, simply because of the way
Such a good point.
Where they've been transmitted. So, as a provider, if you get, I don't know, maybe 35 PDF pages sent to you from an HIE somewhere, that's just as bad as somebody faxing it to you. Right. So I think the acceptance and the ability for organizations to say, yeah, I can really use this, is going to have to lie in how it gets transmitted, what's transmitted, and how it can be incorporated into the system that you have. Because
I think that's an excellent point. It is our responsibility as software developers to tackle that, to say, okay, so there's more and more information in the records, both in terms of quantity and what's exchangeable now because of the advancement of standards. And it's our job to make that usable and to say, when something is sent or when something comes in and our EHR is consuming it and presenting it to the clinician or to their staff, what does that look like? And how do we boil it down? And we have solutions that are focused on that because it is such a big issue. I think it also touches on another challenge with health IT recently, and with exchange and with certification, even some of the criteria that we have to satisfy, is that because so many people see the opportunity of all of this health data, there is a lot that's included in certification criteria that does not offer value to the clinician, right? But the clinician is the one being asked to pay for the system. And so what we definitely are seeing collectively across the industry is healthcare organizations saying, I know you put that in your software. I know you completed the criteria, you checked it off, you got it certified. I don't care about that. I don't care about the public health 27 different transmissions that people want or whatever. And it isn't that they don't recognize the validity of it. It's just that they're a little bit resentful of all of that falling on them, maybe disturbing their workflow. Certainly the cost elements of these really regular upgrades that the government is now requiring. All of that is something that we're hearing. And so, I've encouraged stakeholders in the provider space, organizationally, to really advocate for, hey, ONC, hey, CMS, give us more time to take these upgrades, give us more time for that disruption, because I think sometimes policymakers aren't always aware of, let's give some breathing room and the opportunity to get used to the new version before the next one comes around for some regulatory requirement.
Well, and we physicians are so adaptable to change in what we do. We are creatures of habit, absolutely creatures of habit. When you start to introduce things that basically interdict or interrupt your workflow, just because it's available, is not necessarily a good thing. That's why that usability part I keep kind of pounding on when I'm talking to people about that.
Yeah, it's important.
So let's switch gears a little bit. As we mentioned earlier, we have a brand new HHS secretary, and it's going to be basically new people in town. And one of the questions that I get asked a lot right now is the fact that there are things of value-based care. It's kind of exploded in the Medicare space. It's actually exploded in the private payer space as well. Everybody has gotten onto this bandwagon. And we'll get to AI in just a moment, how that interacts with that. But what are you hearing, or what are you thinking about, or people talking to you about how that program, specifically Medicare Advantage and value-based care, is going to go in the future. Do you have any tea leaves that somebody spilled on your coffee table to tell us what we could expect?
I mean, I think the signs are pretty clear from the Republican-controlled Congress, from people in the Trump orbit, that they really like Medicare Advantage, right? They see that as being potentially a cost control or accountability control opportunity. And so I think we will, if Congress is able to maybe use reconciliation process or I don't know where they would find the consensus in today's divided Congress, but if they were to try to make changes through congressional action, I think you would see more promotion of Medicare Advantage. I do think with now Secretary Kennedy and very likely CMS Administrator Oz, that's going to be interesting, because what they talk a lot about in terms of avoidance of chronic disease, management of chronic disease, trying to have a healthier population, that's an effort that takes more reporting of what's happening with patients, and specifically outcomes reporting, right? So a lot of the reporting that providers now have to do for CMS is functional reporting. Did you do this? Did you administer this test? Did a patient log into their portal, right? It's very, did something happen? And it's not really about, did what you do result in a good outcome for the patient? Are they healthier? Was that a positive? So that we can learn from that. So we can say X intervention had outstanding outcomes, and we should do more of that. We should pay better for that from CMS, that type of thing. And, we've talked about outcomes measurement for a really long time in this industry, but we haven't really been able to do it. And I'm curious personally to see, is there a shift in what CMS in particular rolls out over the course of the next couple of years to move us more towards pushing the boundaries on outcomes measurement? Can we take that challenge up again and be successful? I know there's an interest in burden reduction, certainly in deregulation. And under the last Trump administration, we saw the number of measures shrink. So I would maybe think we'll see the number shrink a little bit, but maybe they'll pivot a bit more to trying to get back to testing some of the outcomes sides of quality measurement. So I think it's going to be fascinating.
Well, you bring up a really good point. One of the roles that I have within Medicomp is working with our quality measure team, and how do we create ways for clinicians to actually comply with these quality measures. And the thing that rises to my mind, and it's every year I come up with this: why did they decide to check this particular bit of healthcare, this particular cancer, or this particular marker? And they've made some of these so onerous to comply with. It's going to be real interesting to see where that goes. But I also agree with you that quality measures as a proxy for actual health outcomes may or may not be the best thing to do. We really have to start measuring outcomes.
Yeah, absolutely.
If you do these things, what really happens to the patient. Kind of continuing along with Medicare Advantage, we're about to enter trade show season in our industry. And everybody, including Altera and us, AI everywhere all the time. And one of the things that I've been writing about and talking to people about is how AI has actually, or could have the potential to, enhance fraud in these programs. And we've got a whole office now under the president that's dealing with cost expenditures and not giving us what we really think we're getting. So I'm real curious about your opinion on that, because I read an article, it's now been maybe 6-8 weeks ago, that only 58% of the diagnoses that are reported in the HCC categories are actually supported by anything in the chart. Anything. It was a massive amount. And wow. I was very surprised. So I'd like to have your opinion on how the AI interface between everybody's just kind of falling over themselves to get down that road, but it also has the potential for not being all that great down the road if we don't use it correctly.
Yeah, that's fascinating. I think President Trump did rescind the Biden AI executive order and issue another one to say, okay, let's come up with our own strategy. I do suspect that the government is very interested in their own AI adoption. We saw that certainly under Biden, and they adopted AI in a bunch of different HHS agencies. And I suspect, to your point, one of the places they will look for AI maximization will be fraud detection, in Medicare and probably Medicaid claims, right? You could see them potentially putting out a requirement to the Medicaid departments in the various states that they also adopt something similar for similar purposes. So that'll be interesting to watch. I do think that is an area ripe for adoption. Conversely, you see a lot of pushback, both from patients and families, also on Capitol Hill and in states like California and places, pushing back on the use of AI in prior authorization. And so that's going to be fascinating as well. And you can see some of the patterns there that have really frustrated people immensely. And then California passing something, for example, to say you can't have prior authorization that just makes this snap decision in the same way anymore. You have to have more thorough review of the case and all of that. So I think that's an area, certainly. And when you track AI legislation at the state level, I mean, there are dozens and dozens of bills specific to prior authorization AI that are out there. So clearly a big topic. I think from our viewpoint in terms of AI and how it can help provider organizations, the thing that's interesting, a lot of people hear AI and they immediately jump to thinking, it's the robot interpretation of something that tells the system what to do and there's no human involved. And of course, that's not true, right? There are things where you can have a system tell a pump, for example, to take action or something. But that is not largely the AI use case that we're talking about. A lot of the development that we're looking at is how do we ease the process of using technology? The obvious answer being ambient listening, which is so popular right now. But any number of things. How do we ease the claims process or the denial process? How do we help with scheduling? Just the things that are such a headache for our clients. How can we make that easier? That's a lot of what we're being asked for. It's not necessarily the super fancy bells and whistles that people think about. It's really fundamentals because clinicians have so little time. Their staff are so overwhelmed with the, just minutia of running their practices or their hospitals. And how can we help with them with that? And so one of the things that I really am suggesting in my advocacy is let's really make sure we look at a high risk, low risk regulatory model that should be different, right? High risk, which is, clinician, clinical involvement, things that pose a greater risk of intervention in the care process, the decisions that are made, that's higher risk. That should be regulated very differently than how can we help scheduling or how can we help with, claims remission. So hopefully that'll be something that resonates. It lines up with the FDA's thinking, right? Historically. And so we're hoping that'll find traction.
And I'm fully in agreement with that. One of the other interesting statistics that I ran across just the last couple of days was in the United States in 2024, 850 million health claims were denied.
Yeah.
That's a lot. And
yep, I'm battling too right now. So I hear you.
I'm doing one personally as well with my family. So yeah, it's one of those things that, and I think the rise of AI incorporation in some of this has actually led to that because the rise of denials has also started to go up. So I think that's rife for regulation and retuning.
Well, one aside there, just as an interesting note, is, CMS put out the requirement around prior authorization, right? Mm-hmm. Because clinicians hate prior authorization. They hate the process. And people have tried to say, okay, let's make that electronic so it's faster and all of this. Really good goal. But there's a requirement, in January of 27 for providers to start at least submitting some of their things electronically in terms of prior authorization, but we don't have standards out yet from ONC, and there's no standards requirement there. And so I think that's going to be interesting, because if you look at the AI part of e-prior auth and you have stuff coming in electronically now, the natural inclination might be for AI to be used more because you have more things coming in electronically, but that actually rubs up against these rules that are coming out saying no, less AI in prior auth. So that's going to be kind of fun.
So speaking of those regulations that we were talking about, the ONC has come out with, US CDI version 3. Right now, version 4 is going to happen. Version 5 is going to happen.
Yeah, 6 is out for comment.
Yep. And SDOH has got massive data sets that they want us to collect data on. I'm curious what your colleagues are telling you about that and how they are going to comply with some of that.
Well, as far as certification, you have to make available the version that they put in the newest certification requirements. So you don't really have a choice as far as kind of keeping up. But, I think they went from a certification perspective, they went from USCDI V1 to USCDI V3. So we would expect, maybe the next one jumps to V5, depends, right? We'll see what the regulatory cadence is under the new administration. But we don't really have a choice except to put all of that in our products. I do think we'll see some changes based on political headwinds from some things that are in V3 around gender and sex and things like that. We might see some of that change. So we'll have to kind of undo that probably based on regulation. But, it's another place where, I think some people say, okay, to our conversation earlier, where is good enough? Where is the threshold where you are collecting or segmenting or, making distinctions between huge volumes of data and categories and value sets. And so where do we run out of new things to put in? They haven't so far. They do have new things that are out. But again, some of what they have put in, and, there are things like USCDI Plus and USCDI for public health, things like that. That might be another place where we see less investment from the new administration. And so less places where we need to do more of that work. So we're going to do what's necessary, of course, right? Certification is important. But, I wonder if we'll see maybe that pace of expansion slow down a bit, at least in the next few years.
Yeah, we were working internally at Medicomp on the SDOH component of that type of data. And when I saw that the fact they had every Inuit tribe separately as a reportable entity, I thought they're out of their minds. What in the world is this going to give us? I don't know, but it's going to be really hard to comply with.
Yeah. And you look at also, really practical implications like data storage requirements.
Absolutely.
And how much more data then becomes necessary to store. And our clients, how long do they have to keep things for audit or for various state laws? It's just, I don't know, what's past a terabyte? I don't even know. Like, so much information that people now have to store and keep. And the point you're making only expands that. So yes, I totally am on the same page as you.
Well, we're kind of coming up on the end of our time. I asked this of all my guests. If you had a magic wand that could change one thing in healthcare IT, what would it be?
I think at this point, regulated, well, okay, I'm going to give you two answers.
Sure.
One would be federal regulators take your foot off the gas, let the industry adjust to the changes that you're putting out there, give us more time to do the work, and give our clients really critically more time to get used to that and to use it and to take the upgrade. So that's number one. Number two would be there is a tremendous volume of policy making that is taking place at the state level right now. So just hundreds of bills that touch health IT, largely around AI, cybersecurity, patient consent and privacy, and interoperability. So it's all well and good that the states are recognizing the great potential that exists with all of this data, but 50 different flavors is really, really hard for software developers to navigate. And so we would much prefer a federal framework for AI regulation, a federal framework for cybersecurity, patient privacy. And I don't think we're necessarily going to get that, at least holistically, from the current Congress. But what it means is we end up having to do development for, Kentucky and then California and then Washington. And it's all these different little tweaks. That's not only hard for us, but it's hard for our clients who do work in multiple states. And so if I could, wave my magic wand, I would say, to the states, at least come together, at least take some consistency in your approaches at a minimum, but really, please, Congress, can you put some frameworks in place so the states don't feel like they have to do this? That would be such a beautiful gift.
You've got a lot of support for that wish.
Yeah.
When I've been talking to a lot of the states about this. Leigh, it has been a pleasure having you.
Yeah, no, this was fun. I mean, I'm a health policy geek. I love talking about this stuff. So we could have talked for 2 hours. I would have been happy.
If somebody wants to get a hold of you and ask you questions, how can they do that?
Well, I am on LinkedIn is probably my best spot. So if you want to look me up there.
Very good. Thanks a lot.
Yeah, thank you.
That's all for today. Thanks for listening to Tell Me Where It Hurts. Tune in to Healthcare Now Radio and Podcast Network each month for the latest episode. To learn more about Medicomp systems, visit our website at www.medicomp.com. You can also follow us on Twitter at MedicompSys or myself at MedicompDoc, or check out the show notes for links. See you next time.